Thanks very much, Tracy, and thanks to the organisers for the invitation. I wanted to start the presentation just to talk about eradication versus elimination. There's a lot of discussion at the moment about global eradication of hepatitis C, but just to set the scene and to inform you of how difficult it might be, eradication is the complete and permanent worldwide reduction to 0 new cases of an infectious disease through deliberate efforts with no further control measures required. Now, with a therapeutic intervention for hepatitis C, even if that therapeutic intervention was free, we would not eradicate hepatitis C globally. Combination prevention measures are required, particularly the development of a highly effective vaccine if we are going to get global eradication. But we may be able to eliminate hepatitis C from certain populations in certain settings. So elimination is the reduction of the incidence of infection to 0 in a defined geographical area or within specific populations. So I think that may be achievable even without a highly effective vaccine. It'll still be tough, but I think we should move forward with attempts to eliminate hepatitis C in various settings and within particular populations. There's been some modelling work that we've been involved in that demonstrates how high a treatment rate we'd need to get to bring the rates of hepatitis C down within the population of people who inject drugs. So we, with Natasha Martin and Peter Vickerman, looked at 3 cities, Edinburgh, Melbourne and Vancouver. And why it was important to look at different cities was that these cities have different epidemics among people who inject drugs. You can see the rate of chronic hepatitis C in Edinburgh is relatively low, 25%, 50% in Melbourne and 65% in Vancouver. The population sizes were different, obviously, in those different settings. The one thing that was uniform was at a very low treatment rate, with treatments ranging from 1 to 8 per 1,000 individuals treated per year, so universally very low. So we wanted to see what would happen with the advent of new direct-acting antiviral regimens. So we modelled the current low treatment rate and then a scale-up over a period of a couple of years if you had access to all oral interferon-free direct-acting antiviral regimens, and then a stable treatment rate, and looked at the impact of different levels of treatment uptake on the prevalence of hepatitis C in the populations. Firstly, looking at Edinburgh, you can see that even at relatively low treatment uptake, you get quite significant reductions in prevalence of hepatitis C in the population. If you scaled up to a treatment rate of 80 per 1,000, so that's 8% of people who inject drugs with chronic infection being treated per year. So that's still a very big achievement to get to that level when you think that the current rate is under 1% per year. So at least a 10-fold increase to reach that level, but potentially feasible. If that were achievable, in fact, you would bring the prevalence of hepatitis C down to very low levels by 2022. As the prevalence increases, the job gets tougher. So in Melbourne, with a higher baseline prevalence, if you scaled up to 80 per 1,000 being treated per year, it would take you until 2027 to bring that prevalence down to less than 5%. And in Vancouver, an even more difficult task because of the really quite high baseline chronic prevalence. So even at that 80 per 1,000, it would be well beyond 2027 before you would get the prevalence down to under 10%. And if we look at the rates of treatment uptake at the moment globally, you can see that we have 2 problems. One, we have very low treatment uptake, and this is rates of treatment uptake not among marginalised injectors. This is the broad population treatment uptake rate. And you can see that in all countries, it's less than 8% per year. The other big issue in terms of impact of therapeutic intervention is that the diagnosis rate is really quite low in most settings. Australia is one of the countries that has one of the highest diagnosis rates at around 80 or 85%, but there are many countries, including the United States and United Kingdom, where less than half of the population infected with hepatitis C are diagnosed. So even at the rates of treatment uptake in countries such as France and Germany, and pretty reasonable diagnosis rates, that still is below the levels that we would need to get to have a sizable impact in terms of treatment as prevention. We certainly need improved therapies. I've borrowed this term perfectavir from Dr. Jordan Feld, but just to give you an idea of what would be the best therapeutic intervention in terms of treatment as prevention. Clearly it needs to have high efficacy, so we would want cure rates above 90%, little or minimal toxicity, once daily dosing. It would need to be pan-genotypic, I think, to have its biggest impact. Short duration preferably. We're very confident that highly curative 12-week regimens will be available shortly, but it would be even better if we could get those treatment regimens down to 4 or 6 weeks. And clearly, cost is going to be an issue. The pan-genotypic aspect of the treatment is clearly demonstrated here, where you can see the different genotype distribution across the globe. In a country such as Australia, about 55% are genotype 1 and 45% non-1. North America has 70 to 80% genotype 1. Look at a country like Egypt, where it's the vast majority of cases are genotype 4. So really quite varied in terms of the genotype distribution across the globe. But there's some very promising data in terms of interferon-free direct-acting antiviral regimens broadly, particularly in genotype 1, and some more recent data looking at a pan-genotypic approach. So this is a combination, all-oral combination of sofosbuvir, the nucleotide analogue from Gilead, combined with a second-generation NS5A inhibitor, GS5816, given for 12 weeks in different genotype populations. And you can see that the sustained virological response, or the cure rate, measured 12 weeks post the end of treatment, is above 90% across all those genotype groups. Now this is a phase 2 study, small numbers, and we're awaiting the phase 3 outcomes, but incredibly promising in terms of a potential pan-genotypic regimen. But we need enhancement of harm reduction. We don't just need increased access to therapy, we need improved prevention strategies broadly. It's clear that combination Hep C prevention strategies will be more effective, and there's nice modelling data to show that. I think it's important in terms of engagement point for hepatitis C testing, referral and treatment. It's clearly required for HIV prevention anyway. In a systematic review, you can see here that a relatively low proportion of countries have implemented needle and syringe programs. We also have a low proportion of countries that have access to opioid substitution treatment. So there's a lot of work to be done in terms of effective hepatitis C prevention strategies in terms of implementation. But we do need to evaluate Hep C treatment prevention in different settings. Some of the potential settings clearly are community-based people who inject drugs, prison settings. We have a large prison-based treatment prevention project that will be rolled out later this year, that will be evaluating therapy in 2 New South Wales prisons here in Australia. HIV infected, men who have sex with men, and also the perinatal setting to look at whether treatment of pregnant women in the 3rd trimester is going to have a benefit in terms of preventing perinatal transmission. What are some core principles in terms of treatment prevention? I think the most important principle is that individual health benefit needs to be central. So I think the strategy of just moving in and treating everyone to hope for a prevention benefit has to be built on a foundation that the individual who's going to be treated, one, wants to be treated and is going to gain a health benefit out of treatment. Community partnerships in development and implementation are crucial. It should enhance rather than undermine harm reduction measures. I think it's important also to look at the impact on risk behaviour as a component of the overall evaluation of the program, and access to retreatment for individuals with reinfection should be built in preferably to protocols. I'd just finally like to acknowledge many people who have supported us in terms of our work at the Kirby Institute in Sydney, including in our treatments prevention work. Thanks very much.